All right, I think we'll get started. Let's wait for these guys to see when they're ready. I think we're close. Probably a few more people coming in still, so. Wait for Christine to tell me, give me the thumbs up. Welcome, thank you guys for coming tonight. I'm Dr. Jana Valine. So I'm one of the family practice and sports medicine physicians here at Rejuv Medical. So I specialize in family practice and sports medicine. Obviously, that's what my training's in, but also in regenerative orthopedics, what we call regenerative medicine, interventional orthopedics, as well as medically supervised weight loss, health restoration. So kind of a little bit of everything that we do here. So my background is we do our typical training and residency and fellowship, and that's where we get the primary care and the sports medicine from. And then there's a couple of fellowships now out there for regenerative medicine, but I was already through by the time they had those. So a lot of the training we now do is actually after we've already been out in practice for a while. So it's a little bit different than the typical kind of training programs that most people go through. Do you have your microphone on? I probably don't. So I'm waiting for them to just, yeah, I'm not, I'll start like officially, just kind of give you a little brief. Yep. So I'll turn it on when they, I think it actually turns on when they start that. So let me go. I don't know if it's actually to project in here or if it's actually for that. I'll check with him. Can you not hear me? Pardon? Can you not hear me?
Not the greatest.
Okay. Can everyone else hear me okay? Okay. Do you want to come sit up closer? I can. Yeah. Yeah, I don't know. We had this last night. I think it was for the camera, but I can see if there's a way to actually, but sometimes it ends up blaring people kind of out of here. Is it going, Christine? Should I start? Yeah. Oh, okay. I didn't know that was the like camera and stuff. Yeah. Oh, I'm good. Okay, sorry. I started and then I didn't realize that because she asked about my microphone. So I guess we are official. Okay. So is that a little bit better? Because yeah, the microphone is for the camera. Do you need me to talk louder? Well, you might just want to go and wait till it's on YouTube and you can slow it down. So that's been a lifelong struggle, and it's just, you know, about as slow as I get. I'll try really hard. So yeah, so that's a little bit about my background is. So I did the very typical training, family practice, sports medicine. You do your residencies and fellowship. I practiced for a few years, got really frustrated. I was actually up in Crosby and Brainerd. I was like, I don't really like my job. Like, people weren't very happy with me. I was doing the very typical steroid injections, maybe some physical therapy, and then we'd send them to surgery. So I started to look for something else. My husband actually happened to find this job. He found this, like, there's this job down in St. Cloud you should look at. Like, it's close enough to actually drive. I mean, it's a little bit of a drive, but close enough. It's like they have a gym there. You get to wear scrubs to work. And I was like, all right. So I actually applied. They weren't really actually looking for someone at the time. It just happened to be an old application. And so I came down to interview with JR, who is our CEO that you saw in the video. And then Dr. Baumgartner was like, yep, this is perfect. This is what I want to do. And so interestingly, at the time, I'd only heard about stem cell, because that's, I think, the buzzword people have heard is stem cell and PRP, when really there's a lot more treatment options. So I kind of came in, I had a little bit of ultrasound background, but not much. So the last few years, I've just done a lot of one-on-one training with Dr. Baumgartner, which I've been very lucky. He's a leader in this field. He does a lot of training, and so he's trained me, and so now I get to go help him train other doctors to do this. And so it's kind of a very, you know, almost like a little mini fellowship that I got to do here. And we do a lot more than just stem cell and PRP. So we do a lot with nerve injections, and we'll talk through all the different processes today of kind of how we do things here at Rejuv and what our goals and expectations are. But really what we're trying to do is, how do you actually get, you know, maybe not to have surgery. If someone needs to have surgery, we're well aware of those indications, and so we send people to surgery when they need it. But what we're finding is that a lot of the surgeries that are being done probably aren't necessary, and maybe they were if we didn't have anything else to offer, but now we do. And so we're finding that we're getting really good results with doing some different treatments that can help people avoid surgery. They don't have the downtime, they don't have the cost, and they can keep their function, and they can keep their actual normal anatomy. So we're not going in and cutting and changing things. We're trying to keep that normal anatomy and actually get things to heal. And so my goal for you today is to help educate on what happens to our bodies first if we have trauma, we age, we have degeneration, we get arthritis, you've had surgery, what actually happens to our body, and then what can we actually do to help reverse this, what those options are, and how you actually get really good outcomes from that. So we're going to talk a little bit about optimizing our outcomes, how do we rebuild, and how do we heal. So I kind of gave you the, usually I go through this about, and I put this up there as like the alternative, because I think that's what people tend to think of us as. And really, I think of alternative as we give you an alternative option. You know, it's not alternative like we're doing something that's kind of off to the side and not really not really well known. This is all evidence-based medicine. There's a lot of evidence out there for this. There's a lot of research and a lot of studies, and I'll show you all of those. So just trying to kind of retrain our thoughts when people think of alternative, medicine, alternative providers, that really it's not this kind of crazy thing over here that someone's doing, that there's just an alternative option. And so I think everyone should get all of their options. So if you're seeing someone, they don't know that this exists, they can't educate you on it. And so that's why more patients are going out and trying to educate themselves, because if you don't know your other options, your doctor might not. And I think people are pretty hard on doctors for not, like, how did they not know that? And you have to know a lot, especially our primary care doctors. I've been there, I've done it. You have to know a lot about a lot of things. It's not a little bit about a lot of things. You have to know a lot about a lot of things, and you're always trying to keep up on meaningful use and what buttons you have to click to get paid and to not get in trouble, and you get 7 minutes with your patients, and then you have all these other things in primary care. So I think we have to be a little easier on doctors and just understand what their constraints are. And I think people always assume that they're closed-minded, and I would agree. I think that there are some that are. But I think part of it is they don't know, and what you don't know, it's hard to change. It's kind of scary. And when someone just brings you like and says, hey, I Googled this, it's really hard to conceptualize, well, what are you even talking about? So if you can go and be educated on these therapies and what your options are, and you can bring them research, it's a much better relationship that you'll build, and you'll help teach them. And they're like, oh, there's this research. Oh, this is really interesting and really fascinating, versus, well, my friend did this. It's, from a doctor's brain, you kind of get very defensive right away because you are expected to know everything, and we don't know everything. And I think that's one of the best things about, if you find a good doctor, they know when they don't know, and they're open and willing to learn from you just as much. You just have to really bring the education and start to train yourselves. So educate yourself as much as you possibly can. And so this is my mom and I, and so we've done quite a few races together, and so she's one of the big reasons that I ended up here as well. And so unfortunately, I did not know about this when she went through all of her problems. And part of it is, as her and I did some races, she ended up injuring her ankle. She got ankle arthritis. And I kind of told her, I was like, everyone tells you to treat everyone like your mom. And I did. I told my mom what I told all my patients. I was like, all right, take some anti-inflammatories, do some topical anti-inflammatories, and it worked for a short time. And, I look back, I'm like, that was a really bad idea. We now know that anti-inflammatories, and we've known this for a long time, it just wasn't something I was trained on, that, the more people take anti-inflammatories, things like ibuprofen, Advil, Aleve, that they have an increased risk of going to a hip or knee replacement. So we've looked at that, and there's studies showing that it causes cartilage breakdown. It actually causes, decreased bone healing. And so a lot of the surgeons have told people for quite a while that if you have a bone break, some are in the camp you don't take any anti-inflammatories, and some are in the camp that you can. And the ones that don't, because there's research out there showing that it can delay your bone healing. It's shown that it decreases your stem cell function. So your body is making stem cells all the time and repairing on its own. And if you're taking some medications to inhibit that, it's going to inhibit your body's natural healing process. Plus, there's this whole host of other effects of the anti-inflammatories. So the gut issues, the heart issues, the bleeding issues. The list goes on, but even just from an orthopedic standpoint, you can have an increased risk to having more breakdown. And so I looked, you start looking at that and you're like, okay, well, that didn't work. And so what's next? We always tell people, okay, cortisone injections or steroid injections. And so, yep, she went down that path, and it was like the first couple worked really, really well, and each one worked less and less. And I look back and I think about it, I'm like, yeah, that doesn't really make sense when I tell someone, I'm going to do this injection to you. It might work really well for you. Most of the time it does. And each one I do, you're going to get less relief, and it's going to last a lot less longer, and eventually it's going to stop working. Like, what kind of treatment is that, right? Like, you start to think about it, you're like, yeah, it made sense at the time from what I was taught and the mentors that I trusted. But then you start to look at the research and like, this doesn't make sense what I'm telling people. It doesn't make sense that I should be doing something that they're actually getting less and less relief. And you go back, and both the anesthetic, the numbing medicine in the injection, that they have it as a carrier, plus the steroid itself at those high doses actually both cause more cartilage breakdown, and they can actually cause more damage to the joint itself. So that's actually why they work less and less as you do more of them, as they're actually causing more progression of your arthritis and the breakdown. And so, she went through that whole process, and I'm like, oh, what were we doing? You probably would have, like her progression in 2 years went from being very functional and still doing a race to not being able to go up and down stairs. She couldn't play with her grandkids. She couldn't sleep. She was stressed out. And so as you know, and it's like, I think you always have one of those personal things that happens to you that really makes you step back and look at what you're doing. Like, gosh, you know, so I started to look through, well, what are some alternative options to steroid injections? You start to find this research, and that's where I was like, I really shouldn't be doing this. And so trying to figure out and so I think, you know, those things happen to you. And I still didn't know about this place when we went on the cortisone. She actually ended up going to the orthopedic surgeon, and she had an ankle fusion. And it was literally like a month later I found out about this. And I was like, oh my gosh, like her and I have been talking about this, like there's got to be something different. And I had been researching it. I just hadn't found this place yet and realized that there was something this close. And so interestingly, she's at, you know, I live down by Rochester's where I grew up, and so my whole family's gone to the Mayo Clinic, right? So they've had the Mayo, and even then, this was a few years ago, they weren't doing this yet. They weren't talking about it. It was, you know, NSAIDs, anti-inflammatory surgery. And so I think we need to understand that it's coming around. People are learning about it, but we still don't know, you know, as much as we need to know, and we still got to get other people on board with this. And so I think, you know, looking back and being like, oh, I told her the wrong thing, you know, and so unfortunately, that happened. She's done very well, and I think the big piece for her, she's like, you know, it's okay, because she's like, I have hope now. Like, she's like, I was so scared to be in that kind of pain again that I would not be able to take steps. I would not be able to go up and down stairs. She's like, I've recovered, but the bigger piece is I know that if my pain comes back, I have an alternative option now. Like, I know there's something else. And she's like, that's so powerful for people to have that hope that there's something else, that you don't have to be in pain. And I think that's something that's really taken away from me, like that I took away from that. Is like, all right, sometimes we make the wrong decisions, and maybe it wasn't the wrong decision at the time. Maybe it was the right decision, but this is what happened, and we deal with it, and now we know, okay, this is what we're going to do. This is what happens, and we have this new treatment that we can offer. And so for her, she would have never done another race with me. And since she, like, once she realized, because she's so scared, she's like, nope, I don't have a limited number of steps. That's what my surgeon told me, is use your steps wisely. She's like, nope, I know I have unlimited steps now because you can help me. And so understand that even if surgery is sometimes needed, maybe it's not, that we do have these options to help treat pain and give people an alternative option. The other thing with this comes, when we start talking about alternative options, is she kind of dodged the bullet on the narcotics and the opioids, which is a huge thing. Everyone knows about it. We've talked about it. FDA has put out things saying, hey, they have a high risk of overuse, abuse, and death, but they've done nothing besides say don't give them. So when I went through school, I actually had to sit in front of the board before I got my license, and they said, you will treat pain. Like, you will treat pain and you will give patients narcotics. Like, that was how I got my license. And so you learn that that's how this problem came about, as we were giving people pain medications. And now they're like, nope, we were wrong, caused a lot of problems, don't give it. And we're like, but now what do we do with people's pain? Like, how do we treat it? We haven't given doctors an alternative option to treat pain, and that's what we're here for, is to not just only treat patients, but teach other doctors how to have other alternative options. And so, you know, this is kind of, my husband and I, he's also a doctor, and so he's actually trained in prolotherapy as well, and he works at the VA. So it's kind of been nice, like I started something, he was able to start at the VA, and so we've kind of been able to start to expand this and help other people really realize there's alternative options here. And him and I have traveled. We traveled before we had our son, and it's just interesting when you go different places that everyone really thinks of, like, you know, the American care is really being the end-all be-all, and we're really, really good with trauma, we're good with emergency, we're really horrible with preventative health and with actually managing pain. And so you go and they're kind of like, well, what do you guys do? And it's like, yeah, we're really good at this part, but we're really bad at this part, you know? And you kind of get a very different perspective when they're like, well, why do you guys work so much? Why do you guys not have siestas in the middle of the day? You know, it's just an interesting concept that, as great as everyone thinks we are, we're not always as good as they think we are, meaning that we don't take care of ourselves very well. We don't have very good preventative health. We don't have very good lifestyle medicine, and we don't help teach people, and we also don't have a society and culture that actually helps grow that. So I think it's a big thing too, is like, as a society, as a culture, as communities, we need to honor that we need to get enough sleep. We need to manage our stress. We need to come together to actually help people have better lifestyle medicine. And so background and training, so obviously I work at Rejuv, and I'm trained with Dr. Baumgartner. We're affiliates of Regenix. They were the first ones in the U.S. to do stem cells back in 2005. And so they have a very advanced academic lab. They're constantly doing research. And so as they're coming out with research, we're able to use that information. And we have the registry of all of us Regenix physicians. They've been monitoring now since 2005. So we have a lot of data, you know. So they have research, plus we have all this data of all the patients, and we can split those patients out and say what are the outcomes on that. So that's been a big benefit. And then we're also members of the Interventional Orthopedic Foundation. And what that is, it's a nonprofit. And so they actually have their own training course that I've had to go through, and there's different levels. So there's only a handful of us in the US who've gone through all those levels and passed them, and because it's actually a pass-fail, which is really interesting. You don't see that anymore. It's like you pay your money, you get your certification. So they actually have you go through a pass-fail both for written tests and actually seeing you do those procedures. So I've done that. So kind of have these different levels, and there's a lot of other groups out there that help train. And so it's kind of been a very humbling experience where you're just like, gosh, this is so new, it's ever changing, yet you're learning so much. And then you have these people who've been doing it for a long time, and just the quality of what they're doing and the openness to change, because I think that's the big difference. Is traditional medicine is very kind of, this is what we do. You know, it's really hard to change that. This group is just like, all right, that worked for you, let's try it. Like, everyone's really open to trying new things, and it's really fun because you know, like, okay, I have some different techniques. I'm not locked into this is the only thing I can do. So let's talk a little bit about arthritis, because that's usually the most common thing in pain. And so once you get a broken down joint, you know, people start to get broken down bodies. And I think, you know, I hear that a lot from people. It's like, man, my knee started hurting and now I feel like my whole body went to hell, excuse my language. You know, and that's because that's how they feel, is like, what happened? This body part started to break down and now I feel like everything else does. And we're starting to realize that what happens with pain and what happens to those nerves as they release certain pain responses actually does trigger more breakdown. It triggers your whole body, and you feel fatigued. You can cause depression, it can cause anxiety, it can cause sleep disturbances, it can cause hormonal imbalances. So we have that to look at and say, okay, like, that is part of the pain response. That's probably why people start to feel like they go down the breakdown pathway versus the rebuilding pathway when they get to a certain age or a certain degree of pain. And so we know we need to treat that a little bit differently and look at that big picture. The other people start to feel very helpless and they start to feel very hopeless. And I don't think we always honor that, and we need to make sure that we're honoring, like, okay, what has this done to your life? What has this done to the quality of your life? Because people don't come, I mean, now they come in saying, well, I have a meniscus tear on my MRI because that's what they've been trained, but that's not why they're really there. They're there because they're in pain. So we have to kind of get away from this, my imaging shows me this. It's, well, where do you feel the pain? And so you guys have kind of been, if you've gone to other doctors, you've kind of been great, and show me, point with one finger, where do you hurt? You know, and they're looking at the imaging, and it's like, no, I want to know, tell me everything. Show me with your hands, where do you feel pain? What bothers you? How has it affected your life? Because that's how we get really good outcomes, is looking at that big picture. So people kind of have realized that arthritis, or the osteoarthritis, which is the most common, is the wear and tear. That's how we usually describe it. But that's really minimizing the problem. So yes, the cartilage that lines the end of your bones, the meniscus in the knee, labrum in the hip and shoulder, they start to wear away. That cartilage wears away. What happens with that, though, is you start to get kind of a very unhealthy joint environment, and that triggers more pain. You don't have this nice, robust environment anymore. Your body tries to clean it up, but in doing so, it's actually causing more problems. The other thing that happens is there's ligaments that stabilize all of your joints. So in the knee, there's 2 on the inside and 2 on the outside. If one side collapses, that ligament's no longer taut and the other one's getting overstretched. So you get some ligamentous laxity, meaning that you get a little bit more motion in your knee. It's not something you feel all the time. It's this micro instability, and that's going to cause more and more problems. So if you took a stack of, of wood together and you wrapped it really tight with a rope and put it down a river, if it's really tight, nothing's going to happen to it. But if you start to slice those ropes, what's going to happen? It starts going to move more. The more it moves, the more the ropes start to break down. So that's how your body works, is once you have a little snap, it's going to progress a lot faster. And so you have to do 2 things. You have to put new pieces of wood in, and you have to redo the rope to get good results. So that's part of the concept, is you got to treat the joint, but you also got to treat the stabilizing structures. So what we do here at Rejuv is we do more of a combination regenerative approach. And by that I mean you can go other places and they will take your stem cell, your PRP, and they will just inject it in your joint and have a good day. And you probably get some results, you probably get some good results, but you're probably not going to get as good of results as you want. And the problem is they're not looking at all of these different things that affected, well, what caused your pain in the first place? Why did you get knee pain? Why did your shoulder break down? What happened? And then what's been a cause of that? So what's happened because you had the pain? Our bodies are very smart, and so a lot of times we've already compensated and we've got abnormal movement patterns, abnormal functional patterns, long before you ever get pain. And that's well, my knee hurts and now my back hurts and now my ankle hurts, right? Well, which was the start? I don't know, and by now it's all 3 of the areas we have to address. So the movement's super important. Functional medicine, nutrition, supplements all kind of go together in that, like, cell health, what's your overall health. If we're going to use your body to heal your body, you have to have healthy cells and a healthy body. So looking at that, yeah.
How far does a joint have to deteriorate before you can rejuvenate
It depends on what your goals are. So, and it depends on the joint. So knees still do really well if they have severe bone on bone. Hips tend to not do as well, but it depends on the context of the whole picture. So it depends on the joint. It depends on the person. It depends on all, like, do they have chronic medical problems? Do they have diabetes? Are they on prescription medications? And that's why you can't, if I just said, yes, we can do it, that wouldn't be an honest answer, because each person's an individual and you need to look at that whole picture to give the actual adequate result. And the thing is you're saying, how far gone does it need to be where if I don't have any cartilage cells, can I regrow my cartilage? The answer to that is the regrowth of the cartilage is not the end-all be-all of what PRP and stem cells do. That doesn't happen for a long time, and so people get pain and functional improvements long before that. So we're trying to figure out what actually happens with these, that people get so much pain and functional improvements without actually regrowing a new disc in their back, without regrowing all their cartilage in a new meniscus. So they still do well. Yep. And then, so the functional medicine, we have two nurse practitioners here, and that's what they do. So they're specialists in what basically it's hormone optimization, nutrition optimization, lab optimization. They look at what your symptoms are, they look at your labs, and they try and get everything working back in harmony again. We do a lot with nutrition, so we've been really changing our nutrition plan. We try and stay up with evidence, but also it's always changing because every person's different. So we don't have a one-size-fits-all. It's like, all right, what's your lifestyle? Let's meet you where you're at. Let's look at what's going on, and we try and change that nutrition plan. So we have wellness coaches, we have our gym, and so we work a lot with that. Our supplements, I think that supplements can be very beneficial. My thing with supplements is I don't want them to be like prescription medications where someone comes to me and they have a list of 12 supplements and they say, I take this, and I say, well, why? I have no idea. So to me, you need to know why you're taking something. I think it's super important. If you just take a list of things and you have no idea what they're for, I don't think you're getting the benefit. And that's what happens with prescription medications, is people just keep taking them and they have no idea what they're on them for and why. So I think it's super important, if you're going to work with yourself and use your body to heal, that you know about your body and what these supplements are for. So I want supplements to be for a very specific reason. And so we have some that are specific to regenerative therapies that have been independently tested, but it really needs to be an individualized approach. So not everyone gets the same, like, these are the 7 supplements. For regen procedures, we know which ones actually improve stem cell function, so we have our list for that, but everything else is individualized. Nerve treatments we'll talk a little bit about. That's really where we know that a lot of the problems that come from pain is related to the nerves and some of the chemicals that they release that cause more breakdown, cause more pain, the mood disorders, the sleep issues. So we do a lot of work with nerves that are very different than what people are used to. So instead of the lidocaine and steroids, we use some different solutions to help reset the nerves, get rid of those chemicals, and help the nerves heal. And then we have our regenerative therapies. And so anyone who just does stem cell, who I would really caution, because we have multiple options for regenerative therapies. Not everyone needs stem cell. You know, prolotherapy we'll talk about, been around for over 80 years. Wonderful, been around the longest, and no one knows about it. So just understanding that you want someone who's well versed in all of these to know what you actually need to get the best results.
When you talk about supplements, you actually prescribe them over here if they need them?
Yep, we tell everyone, yep. So we have our little store and we know what to need.
Which one do you take blood samples to see what they're deficient?
It depends. So the functional medicine, yes, they do blood samples. For me, it depends on, like, do you have pain? Is it nerve pain? Is it from arthritis? So it's all based on what your exam shows and what the history is. So one of the things I kind of, if you're looking at, should I do this or not, is, you know, you want the right product by the right, or in the right place by the right person. So we'll talk through each 3 of these things, because if you're saying, am I a candidate, or I am a candidate and want to do this, this is what you want to look at, is, does the person know which product to use? Are they going to get it in the right place? And are you really being seen by the right person at the right clinic? And so there are, like I said, there's different types of regenerative therapies. There's prolotherapy, PRP, and there's stem cell. And so really what these do is they actually cause an acute inflammatory reaction. And so we've always told people inflammation is bad. And yes, chronic systemic inflammation is not good for you, but you actually need acute inflammation for healing. So if you sprain your ankle, it gets big and swollen because your body wants to bring all that blood to that area, to bring those platelets there, to bring the stem cells there, to help that area heal. You need those growth factors. So that's what inflammation actually is. It's a healing response. Now, if that healing response, that inflammation goes on for too long and you get chronic inflammation, it's not so good. But if you snuff it out the first day because you ice it, you take a bunch of ibuprofen, you go get a steroid injection, you just stopped your body's natural ability to heal. So what we're doing is we're going back with either prolotherapy, which is dextrose, PRP, your body's blood product, or stem cell, and saying, okay, this area needs to heal. It was damaged, and you help your body re-heal that area because I kind of forgot how to. I'll go through it all. Yep, and we'll have time for questions at the end too. But yep, you guys can ask questions, but yep, we'll go through it all. So that's how these all work, and they're all different levels. And so if you kind of think about like prolotherapy would be if you only had one of these guys. So I used to have Paw Patrol, but my son's getting bigger, and so now he's into superheroes. So I'm learning who they all are. And so prolotherapy would be like if you had one of these guys from the team. They can do the job, but it takes them longer, and it takes more treatments to get there. So prolotherapy, like I said, has been around for over 80 years. It's using dextrose to actually go into a joint and irritate the area and stimulate a healing response. Plus dextrose, which is a sugar analog, actually has a really positive response to nerves. So if you eat a bunch of sugar and it goes through your bloodstream, not so good for joints and nerves, but when you inject it locally, it works differently on the receptor of the nerve and is very helpful in healing. So two totally different concepts. And so that is a very specific technique that works extremely well. It has multiple level 1A evidence behind it. It's just people have not heard about it because it's cheap, it's easy, and it does take more injections, but it does work very well. And so PRP would be like having 2 or 3 of these guys. It's a little bit stronger, a little bit more potent. You're going to get a little bit more of a response. So what that is platelet-rich plasma. And what that is, we draw your blood, we spit it down in a very specific technique in our lab, and we take those concentrated platelets and they get re-injected back into the area. And so that's under a specific, you know, it's not just into the joint. It's I put it where I want it, and I know that based on talking to you and examining you. So if you have someone who doesn't touch you, they don't know where the injection needs to go. You need to have someone who has really good exam skills to know, is that ligament a little bit lax? What's the ultrasound show? So we look at all of these factors. And then stem cell would be like if you had this whole team. So they're just kind of an even more robust healing response. And so stem cell is actually taken from back here, so from back of the iliac crest, so it's bone marrow stem cells. And we take that, and again, it gets processed and re-injected back into the area that needs to be treated. And that's also with a pre and post injection. So it helps optimize. So you kind of have these 3 injections over a week to help optimize your stem cell outcomes. So you get a much more potent, robust response to healing with stem cell. And then PRP is kind of your middle guy, and prolotherapy. And there are some benefits. Sometimes we choose one or the other based on the severity of your pain, the severity of the any downtime. We might go prolotherapy. I have some young people, you know, they're young, they're otherwise healthy, they have a trauma. We can go the prolotherapy route. If you have someone who's older, they have really bad arthritis, we're going to go the stem cell route. So we choose these based off of individual.
How do you get the marrow out of the bone? It's all sealed.
What do you mean it's all sealed? We have a trocar, we go in. You just use it. It's like a big needle.
Oh, it goes through the bone?
Mm-hmm. Just go through the bone. Yep. Yep. And we have a very specific technique that we use to get the maximum stem cells. So it's not a bone marrow biopsy like people think of, where you're taking a big chunk out. We're just going in and pulling it off. So it's a bone marrow aspiration. So it works very well. It's not too bad. And so people aren't, you know, the concept thought with stem cells is that it actually, those stem cells turn into those cartilage cells. And when you have a petri dish, that is what happens. You can make those cells turn whatever they want. In the body, it's much more complicated. So some probably turn into those cells. A lot of it we think is that it actually makes a healthier joint environment. So instead of that kind of yucky breakdown environment, we think it's actually healing and rebuilding and getting a healthier environment, because people get pain and functional improvements so much longer before you see anything on X-ray or MRI. So we know that that's happening. And the other is that you're tightening those ligaments, all those supporting structures we're working on. And so they're still figuring out the exact kind of, you know, what actually happens in the body. And it's super complicated, but it does work. And there's lots of research studies showing that it does work. And we're figuring out, oh, okay, it's more than just regrowing cartilage. There's so much more to arthritis and pain than that. So I think that's super important to remember, that that's not the end all be all. And so as far as how do you inject, there's kind of different levels. Some people are just doing it blind. They're not using any image guidance. They're doing it by palpation. And some people, the Prolo technique, this is how it's done. They're very good. Some people are kind of like, yeah, I think that's it. There's some low accuracy, meaning that they use some guidance, but they're not really sure what they're doing. And then we're kind of on the end where we do precise guided, meaning that I know exactly where I want that, and I watch the needle go into that tendon, that ligament, that joint, and we inject the right solution into that area. So you need to know like what you're trying to inject in what body part, because what body part I'm injecting depends on what solution I'm going to use. So I might use a different concentration of something based on the area that I'm injecting. So this takes some work, it takes some training, but it helps. It works quite a bit better. And so if you're looking for a clinic, you know, you want someone who's going to be looking at what is the clinical research. You know, do they have, are they, you know, what are they using for their lab? What are they following? And then part of this means that a lot of people post research on their websites, but that's not how they do it. They're not using that same type of stem cell. They're not doing that same type of technique. They're not using ultrasound. They're doing it blind. So in order to use a research study, you have to be using the same technique and the same product to be able to say like, hey, look, this is working. And so I think that's been part of the problem in this field right now, is kind of the still wild west of like, people are using the research, but they're not doing it the same. And so we need to make sure that we're comparing apples to apples, and that you're actually, the research they're showing is actually what they're doing. And that's for you guys to be able to ask those questions of like, okay, that research you posted on your website, is that what you're doing? Show me that that's actually the technique that you're doing. So that's one way. And then, are they tracking their patients? Are they keeping track of who's doing well? Are they using data and changing their treatments based on that data and those guidelines to be able to tell you, yes, based on the degree of severity of this problem you have with all these other factors, this is what I think your outcomes are. So quick on different stem cells. So most people have heard about bone marrow, the embryonic and amniotic, and fat. And I'm not going to spend a ton of time on this. Know that bone marrow for orthopedic cases is fine. FDA regulations, safety, most of the research is on bone marrow, and it's the safest so far. So that's why we do that here. We have a technique to get the most results, and so that's what the focus is. I'm not going to say that these other don't work, that the embryonic, amniotic, fat do not work. The question is embryonic, amniotic right now is they don't actually have stem cells in them. They have really good growth factors. They probably have some positive benefits to them, but they've had 3 places now have independently tested the embryonic and amniotic stem cells, and they don't actually have stem cells in them. So if someone says I'm doing amniotic stem cell, it's false advertisement. If they did have stem cells in there, they'd have to go through a completely different FDA process to have it cleared. So we have 2 problems with that. So again, I'm not saying it doesn't work. We just have to be careful that we're not calling them stem cell, because there's not actually live stem cells in there, and that they do probably have some, they probably have a place. We just have to figure out what that place is and make sure that we're saying it appropriately, which is, yeah, they probably have some really good growth factors. They probably can work as a scaffold. They can probably help augment, but what are you know, if you think you're getting stem cell and that's what they're doing, you're not getting stem cell. Fat was used, and there are a few studies, but actually the liposuction used to get fat stem cells is actually a higher risk and has more problems than a bone marrow harvest. So people kind of think, oh, I'm getting a 2-for-1, and you're not getting a 2-for-1. This is not a plastic surgery liposuction. This is a mini liposuction where we're taking fat cells to re-inject. And again, it has its place, but you have to be really careful, because if you manipulate it enough to get the stem cells in a high concentration, that does not fall within the FDA regulations. And if you don't do it that way, it's probably more of just a graft than it truly is stem cell. So you kind of get into this like marketing word, what are people calling them? So we kind of stick to the bone marrow for orthopedic cases. That's our specialty. That's what we do. We don't do any IVs. We don't go down that pathway. I think these other ones will figure out their place, and probably at some point, maybe we'll use them, maybe we won't. Kind of depends. Plus, we have all these other things, as we haven't found we need those, because we do PRP and prolotherapy and nerve injections and lifestyle medicine. So we haven't really needed them as much. And then safety. So, you know, really the pain, swelling, clicking, popping, catching, so minimal. This is what I expect. I just caused an inflammatory reaction. So most people are going to get some pain and swelling. You know, this is more of a prolonged, you know, like if it is prolonged. So very low risk. They're very safe. And again, these safety, this is from bone marrow. Not even from prolop here. This is from a bone marrow stem cell. So again, when you're looking at these safety numbers, if someone's doing something else, they can't use these numbers. They have to go based off the other numbers. And so we're able to inject pretty much, you know, for multiple things. And again, this is not like I'm going to inject stem cells into an IV and say I'm going to cure everything. This is all based on like, what's your problem? What's your exam? What's your history? What's going on? What am I choosing to do? And what area are we going to treat? And what are our expected outcomes? But pretty much all these areas, we have something to offer for people. And so the next question is always, you know, will it work for me? And that's kind of what you're asking. I think, you know, if someone can stand up here and say, it will work for everyone, I don't think that's a true way of saying it. I think I can say, we have something to probably offer every single person to help their pain and improve their quality of life. I don't know if that's stem cell until I see you. I don't know what that might be until I see you and examine you, because there's so many other factors going on. But for the majority of people, almost everyone, we can offer something to help them. So it's understanding what is that something, and people, you know, they come in for stem cell, I'm like, I don't know what's the best. Sometimes it's like, no, I want that, and you have to understand, like, okay, I'm telling you that for a reason. You can go somewhere and get it, but is that really the best for you? So most people, though, we have something to offer. Most people, you can do these treatments too. So the next series of slides is just all the research. So this is a couple of the websites you guys can go to. And we have this all on our website as well. There's infographics on the regenx.com website. This is areas of research on prolol. This is just a few. This is not an end-all be-all, but these are all really good level 1A evidence research studies, which is the highest level. This is just on prolotherapy. Some more on prolo, PRP, even more on prolo. Here's PRP studies, more PRP studies, and again, these are all on our website. Stem cell, there's multiple ones on different areas of stem cell. And there's even more. This I should probably go back and update because I haven't updated this in probably a year and a half. But there's every year, like we go to conferences and it's just like one person after another presenting more and more research and more data. So there's a lot out there. So when people say there's no research, you can say no, there is. There's plenty out there. So will it work? And I think that's where, we have to really say what's going on. And so do you need the ligaments treated? Do you need the tendons treated? Do we need to fix, if you have diabetes, do we need to fix that first? Do we need to fix what's going on in your life? Make sure you're sleeping well, your stress is managed. If you're in too much pain to even think about those things, then yeah, let's do treatments first to treat your pain, and then let's talk about things. The other thing is what else do you need? So, we talked about the functional movement. So bracing, we do a lot with bracing, physical therapy, the gym. How do you actually move well? We have our functional medicine, and then the nutrition piece for us. As far as insurance coverage goes, there's a lot that we do here at Rejuv that's covered by insurance. Prolotherapy, PRP, stem cell is not covered by insurance right now. There's more self-insured companies that are starting to cover it because they're actually looking at the bottom line. And there's more like some auto insurances and workers' comp that are covering the Prolo and PRP. But a lot of our visits, we do a lot with the nerve injections, physical therapy, bracing, and it depends on your deductible and your plan. So a lot of those things will go through your insurance, and obviously how much it covers depends on your insurance plan. But those three procedures, the Prolo, PRP, and stem cell, are not covered right now, unless and sometimes people are checking with their insurances, but just on a whole, they're not. Again, there are some self-insured companies, and that's been kind of a big push the last couple of years, is they're trying to get the self-insured companies, and once that starts to trickle over, I think we'll see a difference. So my husband does them over at the VA, so you can get prolotherapy at the VA right now. Yeah. Yep. So go there. It's Dr. Valine too, Dr. Eric Valine. So he's at the St. Cloud VA. So we were up in Brainerd. He started the program there and came down here. So he's there doing prolotherapy. There's other VAs in the country. There's a few that are doing stem cell and PRP. Not here. They haven't allowed that yet, but you can do prolotherapy, so you can get it covered. And the nerve injections. Yep. And we offer a discount too for vets and for military, but the VA you can get prolotherapy by. And he's well trained. I helped train him. Just kidding. So that from that insurance standpoint, the other question is I think understand that just because your insurance covers something does not mean it's safe and effective, and just because it does not cover something does not mean that it's not safe and effective. So insurance coverage is all about politics and money, and you can go down that whole rabbit hole and have a whole conversation, but just understand what they cover is what they cover, and it's such a much bigger picture than me saying, hey, look at these research studies, I think this would be helpful. And so it's probably going to, I don't know when this will happen. I think at some point it will, but right now those are not covered. And so we talked a little bit about this, just the Wild West of stem cells. And by this I mean there are a lot of people who are claiming stem cells are the end-all, be-all, cure-all for absolutely everything. And whenever people quote that, you got to really be careful. So we've kind of said, you know what? We are the experts, and we're really good at doing regenerative orthopedics. We're really good in that realm, and that's the research we follow. So we stick to that, we work on that, but in that realm, you expand to the nerve problems in the spine and the extremities and the overall health. And so that's what we're looking at. So we have to be careful. And the good and bad is when it's not regulated, it allows us more freedom to do things that we want to do. But when it's not regulated, you have people doing things they probably shouldn't be doing. So you just want to make sure you have a qualified physician who's doing it, that they've had the training in this, they know what they're doing, they're using some kind of image guidance, and that they're using the right product for you. And then this is just real briefly, some people need surgery, and we send you to surgery if you need it. I think that's the one thing that helps us having sports medicine backgrounds is we've worked with orthopedic surgeons, so we kind of know when you really, really need surgery, and when it's like, oh, well, normally I would have done certain injections and PT and considered surgery. I can now say I have these other options. I have more tools for you to go through my toolbox and say, oh, let's try these things to keep you from having surgery. The other thing that's happening that's going to help these procedures come around is there's a lot of typical surgeries that are not having good outcomes. So the meniscus has kind of been thrown under the bus. They've had numerous studies that it's not much better than a sham procedure, not much better than PT. So that's kind of getting like, nope, we shouldn't be doing that. Even some of the ortho surgeons are like, yeah, we shouldn't be doing meniscus surgeries on everyone. A lot of the back fusions are getting kind of bad studies coming out, saying they're not as great as we thought. A lot of studies with rotator cuff. So again, sometimes it's indicated, And that's, I think, part of regenerative therapy, where we're saying the Wild West is some people are treating absolutely everything, and we're saying, okay, here's our guidelines, because we can follow some research saying this is within the realm of what's appropriate and adequate for these procedures, and if it's not within this realm, let's talk about, if you can't have surgery, you don't want it, can we still try these things, but what's our expectations and outcomes, or no, I really think you need to go this route, and you at least need to have a surgical consult. It doesn't happen very often. Most of the time we have things we can do that we can try first, but there are cases when that happens, or the way we're treating it, it's not getting better, and then we have to consider something else. And so I think, interventional orthopedics, it really is going to eventually replace a lot of the elective orthopedic surgery. That's what's going to happen. It's kind of with cardiology, as everything was done open heart, and then you have interventional cardiology come along. They start replacing all that. It's lower risk. It's easier to do. It's less invasive. And so that's where I think interventional orthopedics will come in, is it will help, replace some of those elective surgeries, and the surgeries will become much more nuanced in what they're doing and when they're doing it, and we'll have this whole other realm of things to help things heal. So instead of having something cut out and replaced with something different, we're going to try and heal those structures that are natural to your body and prevent a lot of the long-term destruction that's happening from it. So less invasive, a lot of quicker recovery. And if you actually look cost for cost, if you're not looking at out-of-pocket expenses, yes, these are way cheaper. Plus you have to factor in like your downtime, your lost time from work, what happens downstream. You get preservation of your biomechanics, so your quality of life stays better. You don't have all the downstream problems. So you have to factor all those things in. So that is what I have for you guys, lots of information. And so we have a lot on our website, and then if you guys have any questions, we have a few minutes for questions.
You kind of focused on the knee joint. What about the hip joint?
The knee is just the most common, so we do all joints. And that's why I had that list of all the things. We do all joints. It is, absolutely, yep. So pretty much every joint we have an option for. So we do a lot of spine. So lumbar spine is probably the second most common thing we do here. We don't do interdiscal, meaning we don't inject into the joint. That's a completely different topic, because they're doing stem cell into the disc. It's a very risky procedure, and you want a very specific person. I mean, I could think of maybe 3 or 4 people I would let do it on me. That's different. If interdiscal stem cell, you're talking about a whole different animal than just like, hey, let's look at the spine as a whole. Let's look at it as a whole complex. It's all interconnected. Can we treat the fascial layers, the muscles, the ligaments? You can help treat the nerves. So we have a really good technique for lumbar spine that we do. We've had really good outcome. But that's my point, is most people don't need their disc rebuilt. That's not the goal. You're not going to take someone in their 60s and 70s and 80s and rebuild a disc, because they have multi-level degenerative disc disease. They have pain from the nerves being pinched and irritated. They have nerve pain from the muscles being atrophied. They have nerve pain because their ligaments are loose. And so it's not that easy. The interdiscals are a very small, specific group of population that you do those for. The majority of the people need a much different type of procedure. And same thing with, like, you're saying, well, will my cartilage regrow? You kind of have to change your focus a little bit when you start thinking about these procedures, and that it's not I'm going to get back to a 20-year-old knee or a 20-year-old disc. It's, how do I stabilize what I have, turn the clock back a little bit, help heal and regenerate, and give a healthier environment, and fix all the biomechanical functions, fix all the areas of pain. And replacing a disc in someone who has multi-level degenerative disc disease is not what's going to fix it. But we have a really good technique for back, so it works really well. Yeah. So it depends on the body part. It really depends on the body part, and it depends on the body part and what's wrong. So if we take just kind of typical arthritis, it's a series, you come in, so one stem cell injection is there's 3 different visits over the course of about a week. So there's a prep injection, then there's the actual stem cell harvest with the re-injection that day, and then we do a post-injection to help kind of kickstart the stem cells into working into gear. So that all happens over about a week to 10 days. And during that time frame, your downtime starts after the harvest. So if it's a shoulder, most of the time you're going to sling for a few days. If it's a hip, a knee, an ankle, kind of a lower extremity, you might be on crutches for a few days. You might just be with a cane or a walker for a few days. Part of it's till you get a brace on. If you have like a big rotator cuff tear, you might be in a brace longer. If you have a big ligament or tendon tear, it might be different. So that's why, but most people, they're back to kind of most of their day-to-day activities within a few days to a week. It depends on your job. I mean, if you're a heavy labor worker, yeah, you're going to have a little bit different than someone who goes and does a desk job. So downtime is pretty minimal, meaning that you're not laying at home. Like you do the injections, you're not knocked out, we give you some medications to help you relax you, but you go home that day and people are up moving around, you're doing your day-to-day type activities, we don't want you laying in bed. So you're up moving around doing your day-to-day stuff. The downtime is more, you're not going to be running, jumping, going for a 6-mile walk. Like your downtime is going to be kind of a restricted range of motion lifting within that time frame based on what was done. So like probably biking, swimming, things like that. You're not going to be running, So, if it was your shoulder, yeah, probably running's going to be a little sooner than if we did your back or lower extremity. But most people are back to we can get people back to some kind of cardio where it's like light walking, biking, maybe elliptical, usually within a week to 10 days. Sometimes it's a couple weeks. So it's pretty short. Yeah. We do, yes, and it depends on the neuropathy. So yes, we do. Yep, and that's really more in those nerve injection realm where it's really looking at the specific nerves themselves, not as a whole. So if someone has like carpal tunnel, which is a common neuropathy, or neuropathy in their feet, there are some specific nerve injections we do for that. The bigger piece of neuropathy is we treat the pain with that, and we look at why do you have it, and then how do we figure out why you have it, and how do we look at that root cause of neuropathy, and how do we treat that part. No, it's actually it's a different solution. So our nerve injections are actually mostly done with something called mannitol, which is similar to the dextrose that's in prolotherapy. It's a different concentration, and that's what actually resets the nerves and kind of helps calm them down, and so that works very well for that. And those ones usually will go through your insurance. Those are ones that a lot of times we'll do them as, they're nerve blocks, they're nerve resetting, so those ones a lot of times will go through insurance. Sometimes if that doesn't work, we will do PRP to stabilize the area, stem cell to stabilize the area. It's called, like, let's say you have wrist instability, that's why you get recurrent carpal tunnel. You might need a regenerative treatment to your wrist to treat those stabilizing structures. There's also parts of the blood product that will also work really well for nerves. So there is parts of the PRP that we can use for nerve treatments, but the majority go down the mannitol pathway. Yeah. Make an appointment. Make an appointment. Yep. Make an appointment.
So what's the cost of your consult? We just can't walk in. Well, we probably don't have insurance, so what are we going to expect for?
What do you mean you don't have insurance? You live in Minnesota. Most people have to have. I have to submit that to Medicare because you have it. If you, let's say you had absolutely no insurance, you had no Medicare, no VA, then we have a cash price that the front desk can give you for that visit. If you have insurance, because of our contracts, we have to submit that through your insurance, and then that depends on your deductible and your plan of what they cover for that visit. So your consult with me is just like any other doctor's visit. It's just like coming in if you were going to go to your primary care for your knee pain. Coming to see me for that is just like that from a coverage standpoint. The difference is what you're going to get from me. So you're going to get a much longer visit from me. You're going to get a lot more information. You're going to get a lot more options. And then we decide, okay, do we need more imaging? If you've had imaging, we ask you to bring it with you. If we need more imaging, then we get more imaging. Sometimes you'll come with hip pain and it's really their back. So I say, all right, let's get more of that. So it really depends. But that visit, I can't tell you what it would cost you unless you truly had no insurance. And then there's a cash price they can give you. But we have to submit those visits through your insurance. And if you go to the VA, then it's whatever your VA, Yeah, just ask your primary for a referral to the pain clinic. You just ask your primary at the VA for a referral to the pain clinic, and then they'll refer you to the pain clinic, and then you go in through that route. Yep. So then that's really the easiest thing is just make an appointment, because then we can tell you what to do. Yep, so because it depends on the severity. So really, it depends on what's going on, your pain, your other medical problems. So yes, most of the time we have absolutely something to offer you for your hip pain, but I couldn't tell you like, yes, you need stem cell today, yeah. Mm-hmm. Yeah.
How would that fit into any therapy or
Well, that's different because that's the gym, so you'd have to ask from our gym side how that works, but that doesn't affect because there's physical therapy, which again, if you have insurance, the physical therapy goes to your insurance. If you don't have insurance, then there's a cash price. But the Silver Sneakers is an exercise program. It's totally separate from the physical therapy in the clinic. Oh, yeah. But and then usually what happens is I start with you. I say this is what I want you to do. You go to physical therapy first. They say let's do a full functional movement screen. Then they send you to the gym and say I want you to work with a trainer. Here's some appropriate classes. Here's what you do at the gym. Yes, yep. Yes. And that's why we have this, right? Yep. So it's not like that's separate. I mean, it looks separate, but I mean, we're constantly talking back and forth. And so that's the one thing with our trainers too is they're more well versed. So if someone says, "Hey, I have back pain," or Dr. Valine said, "I have hip problems and I shouldn't do this," they know what that means. And plus, then we have the communication between me and the physical therapist and the physical therapy in the gym. So they're kind of our liaisons in a sense. Sometimes it's nothing too big and people already work out. I'm like, nope, go for it. I'll talk to the trainer. But a lot of times we kind of have that in between with the physical therapy. Yeah. Yep. You're welcome. Yeah. Yes. Yep. Yes. So for a stem cell for a knee is it's around $5,900. Yep. For that 3-day process. Yep. And that does not. So then like your visit, and so that's the thing is you'd come in, you'd speak with me, we'd do a visit, we'd do an exam, and then we'd say, okay, yes, I think this is right for you, and then we get you set up for that completely separately. Yeah. And that's stem cell. So PRP and Prolo are a lot less. Yep. So that's why we're through the Regenix registry. You can actually go onto theirs, and they actually have infographics so you can put in your body part, and they'll tell it, like they actually have all these really cool infographics so you can look at all these different pain and functional scores, and we're part of that registry. So all the patients we see that we do PRP and stem cell on, there's a form you fill out, there's surveys you get that they actually import that into that, so it's an ongoing updated registry. So that way you can look up your specific body part, and even within that body part, they sometimes have different like knee arthritis versus meniscus tears. Like they separate some of that out a little bit. No, because a lot of that goes and that's so we kind of call this biotensintegrity approach, which is that everything's interconnected. So that underneath the kneecap is still in the context of knee arthritis. So they haven't separated that much. Most of the time we just know that it's more the severity and what else is going on. But yep, it still works very well. And knees do very well. So. Did you have a question? Yeah. Nope, sorry. Yep. Well, that's where I think, having a visit here for your first visit will be very different than what you've had before. So you get a long time with the doctor, so we have a much longer. So we still have our, you come in, rooming procedures, that stuff is all still standard, but we do a much different questionnaire. We talk to you very differently, and your exam is much longer than you probably ever had. So it's all based on your history and what you're telling me, what your exam shows, so a very detailed hands-on exam, and then what imaging may show. So then we take all three of those and we combine them and say, okay, this is what I think is going on, and this is what I think would be best for you. Anywhere from a half an hour to an hour usually. I mean, some are pretty straightforward and pretty quick. It's like, yep, but most of the time it's probably more between 40 to 60 minutes. Yep. Well, there's always going to be failures. Always. Yep. I mean, any procedure is always going to have failures, and that's why we just try and do as good of an exam and as good of a history as we can and give really honest opinions on what we think your success is. But everything's, nothing's 100%. Everything has a failure rate. Our failure rate's not very high. I mean, most people, if they don't get as much improvement as they want, most will get some improvement. And usually there's always something we can do, and if someone doesn't get the results we want, we always go back and look. You know, it's not like saying, oh, well, the X-ray looks good. It's what happened. Were we, you know, was it not the right area? Was it not the right source of pain? Did you go take a bunch of ibuprofen? Was it because of this prescription medication? Is it your diet? Did we not have you in the right rehab? So we always go back and look at lifestyle factors, but also what were we looking at? Were we wrong in the diagnosis? Did we not treat enough of an area? So if something doesn't work, we always go back and figure out why. Yeah. Yep. Yes. Like if it doesn't work, do they get worse? Yeah. Yep. So do you mean like where they actually get worse from the procedure, or just that you? So very few people get worse. You know, if you do it correctly, most of the time, if there's a failure, it's usually that people just don't get improvement. Very few people actually like revert back to like, you know, something that was worse. So, you know, we always tell people there's a chance of it, but it's so, I mean, I can't think of here. It's so minimal, and usually if there's an issue with that, we know, we can figure out why. Like, oh man, it's because, you know, this was happening, or there was something systemic, that underlying Lyme or undiagnosed thyroid problems. So usually if that happens, we look for a root cause and a source, and we usually find something. But most of the time it's just that it doesn't work. It depends, you know, and again, so if we think it's because you just didn't have enough treatment, so if someone has really severe arthritis, and we're like, no, I think you didn't respond because you just need more treatments, then yes, we'll repeat the procedure. If we say, oh, it's because you had undiagnosed thyroid disease, well, fix the thyroid first and see where you're at, and then maybe we need to go repeat the procedure after that once we've diagnosed that. Nope, it's just, it's still the cost each time, yeah. But that's what we do, the whole screen when you first come in is, you know, most people are getting some kind of lab work. If there's any kind of screen that we're seeing on your evaluation that says, hey, there's something here that I don't think is quite right, we're looking through all that before we even do. So one of the things is, it's not like you see us and the next day you're coming for a stem cell. You know, it doesn't happen. We're looking through the evaluation. We're talking to you before to make sure everything's optimized. If we don't see any red flags, yeah, we go for it right as soon as we possibly can. If there's no red flag saying, oh, well, we should be worried about this person not responding, we're going to fix all those things first, and then we're going to go downstream and say, but if it doesn't respond, we go back and say why, and is it because you need more treatments? And usually we'll tell you ahead of time, like, hey, you should expect 2 to 3 of these treatments to get the outcomes that you want to get. Any other questions? Yeah. Yeah. Yeah, the high deductibles made a big difference in people really thinking through, like, what are they going to do? Yeah. Mm-hmm. Yeah. Yeah, and I think that's part of what we talk about is goals, expectations. If someone can barely get out of a chair versus someone says, I want to get back to running, we're going to have a conversation on what does that mean. And so I think that those goals and expectations are absolutely right, which is, you know, for you, that's a huge success rate because now you have pain-free days, which you never had before. And so that's to me, it's a huge success. Like, I think that's really successful. It's going to help the rest of your life. So I think that's, you know, part of what this is I think if you're looking for someone who's just like, nope, we'll do this, that's not the kind of clinic we are. We want to make sure that we're giving people really good, solid goals, expectations, what their outcomes might be, and it's not 100%. We can't guarantee, but we know we have most things for most people that we can offer something to help. And the easiest thing, and that's kind of like, if you guys have any questions, is that's really what we do. We just want to see you guys. We want to see you for new visits. That's the best next step is to say, all right, make an appointment, schedule with us, let us talk to you, let us figure out what's actually going on. If you have previous imaging, x-rays, MRIs, whatever it is, labs, bring them in with you. You can bring them ahead of time. It's super helpful, and we'll start that process and figure out what's going on. Do you guys have questions? Do you have questions? Which is right. I mean, like, you know, get the type of $50,000 to $100,000. So, but, I think that's where, yeah, it costs money, but you kind of got to figure out, like, what do you want? What are your goals, expectations? Does it make sense? You know? Yeah. It's probably both. Yeah, it's probably both, you know? But again, you're missing the point, which is regrowing that disc probably won't fix all your problems. So if we MRI'd a bunch of people over the age of 55 or 60, they're all going to have degenerative disc disease and collapsed disc. There's a huge number that have pain, there's a huge number that have debilitating disease. There's a lot of people with fairly normal MRIs that have debilitating disease. So that disc, if that's just your focus, we're missing a big piece of what's going on, which is that there's much more to your back, there's much more to the nerves, and there's much more because your hip still hurts. So if that's the only thing you want treated, you're going to miss a big piece of the picture. And in order to tell you that, we have to examine you and see what's going on. Is it, yep, I think it's both your back and hip, or nope, I think it's the majority of this. We have different injections we can do to help sort through that too. That's the majority of what we see all day, every day, and so I think that's part of what's happening in the culture of medicine. We get the imaging, and everyone becomes very focused on their imaging, and I'm nothing saying like your imaging is important to me. It's super important. It's very helpful, but I look at where's your pain, where is it going, how does it affect your quality of life, and that's so much more important to me because that's how I figure out what I'm going to treat. The pain you need? So you're trying to think about it more that you're trying to like heal and repair and not completely go back to the 20-year-old me. So you want to give a healthier joint environment. You're going to stabilize the structures. And yes, you can maybe fill some of those gaps. But what we're seeing is people get pain and functional improvements a few weeks to a couple months after they do a procedure. Some of the imaging they're doing are these very kind of high-level, super expensive MRIs. They're looking at these layers. And yes, after sometimes a year and a half to 2 years, they are seeing a little bit of regrowth of that cartilage. Now, if you were like a 30-year-old with some couple layers missing, yes, that will probably regrow out. If you're someone who has kind of that mild to severe arthritis, collapse, it's not going to all of a sudden look like a brand new knee on an X-ray MRI, but you are going to get some healthier layers of cartilage in some cases, but we're not checking it on day-to-day people. So some of these patients are looking at that and check out, oh gosh, what's going on if people are getting improvements, but their X-rays are getting the same numbers.